So we begin today's session. So the first talk article what we are going to discuss is the role of ultrasonography in the diagnosis and management of early pregnancy complications. Okay, so the early pregnancy complications are common reason for women to seek the medical care, and these complications are very commonly seen between the 8 and 11 weeks of gestation. So remember, this particular early pregnancy complications are common between 8 and 11 weeks of gestation. Then what is the modality which is used for the assessment? The TVS, transvaginal ultrasound, is the standard and essential tool for assessment. Most scans will provide clear diagnosis, but some may be non-diagnostic. Okay, sometimes the first scan may not be diagnosed, so we may have to review the scan. We may have to add the TAS plus TAS also, so transvaginal plus transabdominal, etc., etc. Okay, but the TVS remains the basic tool, standard and essential tool for the assessment. So if an intrauterine gestational sac is seen but viability is unclear, what we call it as a pregnancy of unknown viability. Last time also we have discussed in our previous session, there are two important terminologies. One is a pregnancy of unknown viability. Okay, if an intrauterine GSAC is seen but the viability, there are no heartbeats, then we call this as a pregnancy of unknown viability. Second, if there is a pregnancy is not visualized, there is no pregnancy visualized inside or outside the uterus, that is termed as pregnancy of unknown location. Okay, so the beta HCG is positive or urine pregnancy test is positive, but on transabdominal or transvaginal scan you are not able to visualize the pregnancy either inside or outside the uterus, then we will label this as a pregnancy of unknown location. Okay, so pregnancy of unknown viability and pregnancy of unknown location, these are not diagnoses. So it is not a diagnosis. They represent the current status of the investigation. So at this point of time, we are labeling this as a pregnancy of unknown location or pregnancy of unknown viability. It may turn out to be intrauterine, it may turn out to be extrauterine or ectopic also, we do not know, but the current status is this, either PUV or PUL, whatever, depending upon the finding. Then second opinions and repeat scans should be part of standard practice before diagnosing the miscarriage. Last time we have seen about the miscarriage, the when CRL is less than 7, what should be the protocol? When CRL is more than 7 millimeter, what should be the protocol? Those are frequently asked questions. Okay, now let us go to the further. So caution is essential before treating suspected ectopic pregnancy with methotrexate to avoid harming a possible intrauterine pregnancy. So when you are talking about medical management with methotrexate, always think of, can there be an intrauterine pregnancy associated? Can it be an heterotopic pregnancy also? Okay, so you have to think about the intrauterine, or if it is a pregnancy of unknown location, it can develop an intrauterine pregnancy also. We do not know. Currently, it is a pregnancy of unknown location. Okay, so that is what we need to think about before giving methotrexate. Ultrasound and serum markers have greatly improved the early pregnancy management, that is progesterone and HCG. However, misuse or misinterpretation of these tests can lead to serious harm. In a hemodynamically stable women, it is generally safe to wait until a definitive diagnosis is made. So when your patient is stable and you have a case of pregnancy of unknown viability or pregnancy of unknown location, in that particular case, it is always better to go ahead with the conservative management, serial management of beta HCG or maybe repeat scan and all. We will go through the protocol in subsequent slides. So let's talk about the pregnancy of unknown location. Okay, so pregnancy of unknown location is not a diagnosis, but a temporary classification until a definitive diagnosis is reached. Ectopic pregnancy rates in pregnancy of unknown location varies from 7 to 30%. Okay, depending upon ultrasound quality and patient population. Okay, so we have seen the ectopic pregnancy prevalence in the last session. What was the pregnancy prevalence in the general population? It was 11 per 1,000. Okay, in early pregnancy unit, it was 2 to 3%. But if we want to know in patients with pregnancy of unknown location, it will be as high as 7 to 30%. Okay, so if the SBA question is asked, please look at the population with reference to this question is asked, whether it is a general population they are asking, whether it is early pregnancy unit they are asking, or whether in patients with pregnancy of unknown location they are asking. Okay, so the prevalence differs with respect to the population which you are considering. Okay, Now, what are the management options of pregnancy of unknown location? So these pregnancy of unknown locations are typically divided into two. One is a low risk pregnancy and second is a high risk pregnancy. Low risk pregnancy in the sense, suppose you have a beta HCG which is maybe less than 1000, and maybe around say 800 you have beta HCG which is a first beta HCG, and you repeated after 48 hours and you found that it has come to 600. That means there is a drop of around 20-25%. Okay, so there is a quite a good drop. That means this pregnancy is going to fail. Okay, so the management will differ. However, if you have got a rise in beta HCG and this rise is not appropriate as per the intrauterine pregnancy rate, like what we say more than 66%. Okay, but if it is less than that, then definitely it is going to be a high risk pregnancy. We'll see the flow chart in the subsequent slide. So then what we have to do, we have to carry out certain investigations and risk stratification we have to do. Okay, so serum progesterone is there, beta HCG is there, but serum progesterone has got some limitation. Serum progesterone can identify low risk failing pregnancies of unknown location, but limitation is that it misclassifies viable intrauterine pregnancies as high risk and ectopic pregnancies as low risk. Okay, so serum HCG and HCG ratio, that is 48 hours HCG value and the current HCG value. You take out that particular ratio, you calculate that ratio, and it helps in risk assessment. So we have seen that we have to classify this as a low risk or the high risk. Okay, this model is called as M4 model, that is multi-nominal logistic regression. Okay, so this model classifies the pregnancies of unknown location into two: low risk pregnancies and the high risk pregnancy. And what it takes into account, it is the initial HCG and the HCG which is repeated at 48 hours. So 48 hours and divided by current 48 hours divided by the previous beta HCG. That is what we. Okay, so this is validated over a period of 1900 pregnancies of unknown location, and it outperforms both HCG ratio and progesterone in predicting outcomes, and available online for clinical use. Okay, so this is what is the chart. This basically I am discussing today, because if I would have discussed along with last time discussion, there might have been little confusion. Okay, so when we are talking about pregnancy of unknown location, we have to divide whether it is a low risk pregnancy of unknown location or a high risk. Now look at this M4 model. So this is a triage with model M4. The model will assign pregnancy of unknown location as a low risk, where you have to do the urine pregnancy test in 2 weeks, or high risk, that is repeat HCG and or TVS in 48 hours. So the management is, they always ask you in SBA, what is the next step? So first thing, you look into the information what is given to you in the examination. If you are talking about pregnancy of unknown location, or whether you are talking about pregnancy of unknown viability. Last time we have talked about the pregnancy of unknown viability, where you have been given a CRL value, you have done the TBS, you are able to measure the CRL value, and there is no heartbeat. So CRL was less than 7, so we said repeat TBS after 1 week. CRL was 7 or more, then what we said? We said take the second opinion and or repeat TBS after 1 week. So that we were talking with reference to the pregnancy of unknown viability. Now we are talking here about the pregnancy of unknown location. Okay, so now what they are here, it is a SCG ratio they are taking into account. This SCG ratio 48 hours divided by SCG ratio 0 hours. So 48 hours before and SCG ratio at 0 hours. If it is more than 13% decrease, okay, that means it is a good decrease. Decrease of more than 13% is a good decrease. That means this pregnancy is a failed pregnancy of unknown location, and you have to repeat UPT in 2 weeks. Okay, so this we are not much bothered. As I said, initial was 800 and the current pregnancy is around 600. So more than 13% there is a decrease. So you will just repeat the UPT, because this is going to be a failed pregnancy of unknown location. Over a period of time, this beta HCG will become nil. So you will directly repeat UPT in 2 weeks. And if the this UPT is positive, then you will do the serum beta HCG. So when you will repeat, you don't have to do the beta HCG also. They are just asking you to the repeat UPT in 2 weeks. But if it is a positive, then you will do the SCG. Okay. So they give you the value, the first value they give you the second value, then you have to calculate the ratio, whether it is increasing, whether it is decreasing, and with what proportion. Okay, if it is decreasing by more than 13%, you will repeat UPT in 2 weeks. If positive, you will repeat beta HCG. Okay, now let us see. There is an increase, but the increase is more than 66%. This is actually what we are expecting in an intrauterine pregnancy. So that means it will be a sort of going to be a normal intrauterine pregnancy. So just go for repeat TVS after 7 days. Is it clear to all of you? So these two pregnancies will be low risk pregnancies. When there is a decrease more than 13%, or whether there is an increase more than 16%, these are going to be low risk pregnancy. While the high risk, when there is an increase but it is less than 66%, this is going to be a probable ectopic pregnancy, and we are worried about. So we will repeat TVS on day 7, or if the beta HCG is expected to be more than 1000. So initial beta HCG is less than 1000, and it was a pregnancy of unknown location. Okay, repeat beta HCG was less than 66% increase. So when it is likely to be, when you get a beta HCG more than 1000, you repeat at that time or repeat TVS on day 7. That is what is the next step. Now you have a fourth situation in which there is a decrease in beta HCG, but the decrease is less than 13%. So this possibilities that it can be a failed pregnancy of unknown location, or it can be possible ectopic also. So these two are going to be the high risk pregnancy, and for which you are going to repeat serum HCG on day 7. Okay, so this is most of the candidates do get confused because the options which are given to you are very close to each other. Like they will say repeat UPT after 7 days, repeat beta HCG after 7 days. Then we get confused whether to repeat beta HCG, whether to repeat SCG. Then another option is repeat 7 days. Then another option will be repeat if the beta HCG is more than 1000, and you get confused with the options which are given. So just see that low risk pregnancy, what we are going to do, if it isn't going to be an intrauterine like this picture more than 66%, we will repeat after, because we are likely to deal with a normal pregnancy. So we will repeat TVS after 7 days. If it is a decrease and the decrease is good decrease, that means low risk decrease, again straight away go for UPT in 2 weeks, because they give you option repeat UPT in 48 hours, repeat UPT in 1 week, repeat UPT in 2 weeks, and here we have to repeat UPT in 2 weeks. If positive, then we will repeat beta HCG. Why we get confused? Because after the abortion, they ask you to repeat UPT after 3 weeks. Okay, so these 1 week, 2 week, 3 weeks, all options you put C in front of you, one after the other, and you get confused. So if we are talking about pregnancy of unknown location in a low risk population, then if there is a decrease, repeat UPT in 2 weeks. If it is a spontaneous abortion, repeat UPT after 3 weeks. Okay. If there is a good increase, what is expected? TVS after 7 days. Okay. Now coming to the high risk. If it is a high risk, if there is an increase beta HCG, but this beta HCG increase is less than 66%, then definitely we are more worried about ectopic, and the tool of choice is going to be the TVS. So repeat TVS on day 7, or when the beta HCG is more than 7,000. Okay, so if there is a decrease, again we are going to repeat TVS. If there is a increase, we will rely on TVS. If there is a decrease but less than 13%, we will repeat serum HCG on day 7, and then we will decide. I hope this is clear to you. The next step, is it clear, Dr. Sinchana?
Yes, sir.
Yes, sir. Yes, sir.
Yes, sir.
Yeah, okay. I explain you because you should not get confused with options and how to select. Keep yourself calm, think what you are dealing with, and then select the appropriate option. Okay. So this is just a management protocol which is given in the article. So if it is a pregnancy of unknown location and you have hemodynamically stable patient with pain, in that particular case, you may your management may be serum HCG and consider laparoscopy, because the patient is hemodynamically stable but there is a pain. Okay, so we might think of considering the laparoscopy along with beta ECG. Now your patient is hemodynamically stable and patient is pain free. What our up till now we have mentioned, if the patient is stable, better to work up, better to go ahead with the conservative management. Okay, so it is an expectant management which is followed. You take the serum SCG level at 0 hours and serum beta SCG at 48 hours, and then you decide as per the M4 model. Okay, and if your patient is hemodynamically unstable and there is a pain, you go for laparoscopy or laparotomy. This is what is the management which is proposed. Okay, so this is all about the pregnancy of unknown location. Okay, now what we are talking about, the role of ultrasound in the first trimester. Okay, so in which we have seen about pregnancy of unknown location. Now we will talk about what is the role of ultrasonography in ectopic pregnancy. Now the slides which I am going to show you is just a repetition of the previous discussion what we had. So I will go little hurriedly in these slides because all the features, ultrasonographic features, we have discussed in our previous session. So what is ectopic pregnancy? Ectopic pregnancy is an implantation outside the endometrial cavity, commonly in the fallopian tube. It is potentially life-threatening. Risk factors are smoking, pelvic inflammatory disease, previous ectopic pregnancy, assisted reproductive treatment, previous tubal surgery. However, more than 50% of women with ectopic pregnancy have no identifiable risk factor. This is the value of more than 50% mentioned in the TOG article. But if you see the NICE guideline, what we have discussed last time, how many patients do not have identifiable risk factor as per the NICE guideline? Anyone? Last session, it is 1/3 of the patient. NICE says 1/3 of the patients do not have the identifiable risk factor. The TOG says more than 50%. Okay, so these values, there will be little discrepancy in the NICE GTG TOG article. So we will give priority first to the GTG, then to the NICE, and then to the TOG. If the value which is given in the NICE or the GTG is not there, and the value which is given in the TOG is mentioned in the option, then we select the TOG. Okay, so we go ahead in early pregnancy ultrasound, role of ultrasound. So TVS is the gold standard for ectopic pregnancy. Diagnosis in first scan, in 70% of cases you will come to conclusion, and in follow-up scan more than 90% you will come to conclusion that it is an ectopic pregnancy. That is why this TVS is going to be very, very important. Then ultrasound signs of tubal ectopic pregnancy, this we have already discussed along with the percentages. There can be extrauterine G-sac with yolk sac with cardiac activity, that is viable ectopic. Then there can be extrauterine G-sac with yolk sac and no cardiac activity, that is non-viable ectopic pregnancy. Then we discuss about two signs. One is a Bagel sign, another is a blob sign. What is this Bagel sign? It is an adnexal mass with hyperechoic ring. Okay, what is the blob sign? It is a homogeneous mass which is separate from the ovary. Sometimes, these signs can be asked or they can be given in the description, or the report shows this, and there will be some question. So don't get confused. This blob sign is homogeneous mass which is separate from the ovary, while Bagel sign is an adnexal mass with hyperechoic ring. Okay, so ectopic pregnancies are not visualized initially, are classified as a pregnancy of unknown location, often due to early small size, and ultrasound accuracy is with experts hand more than 99% specificity, and older studies has mentioned the ultrasound accuracy of 84%. These values will not be asked, don't worry about it. So this is what is the figure which is shown in the top. So here is an ectopic pregnancy. Okay, so TBS showing a tubal ectopic pregnancy. This white arrow, the majority of the tubal ectopic pregnancies are visualized as homogeneous masses or blobs. Okay, this is as per the TOG. But last time we have discussed what is the common description on the ultrasound in cases of ectopic pregnancy. The NICE or the GTG description was little different that we have discussed last time. Okay, so coming to the management approaches. So the first line medical management is there with a methotrexate. The first line management as per 2012 NICE guideline, but caution before the use is that always exclude viable intrauterine pregnancy to avoid serious fetal abnormalities. Errors in methotrexate use are major concern, especially in USA. And what is the eligibility? Women must be clinically stable, and compliant. The last time we have discussed, the patient should be able to come for follow-up. So patient should be compliant with the regimen and wait 48 hours to assess SCG ratio to confirm the diagnosis. Never on a single beta SCG, don't start directly methotrexate. Wait for 48 hours. SCG ratio also helps select women for expectant and medical management. So we have also seen the expectant management for the ectopic pregnancy. If the beta SCG value is falling, then you can go ahead with the expectant management. And there are other criteria that also we have discussed. What are the criteria for the beta SCG expectant management? Okay, so criteria for expectant management as per this are ectopic mass less than 30 millimeter in diameter, no embryonic cardiac activity, and serum beta SCG less than 1500. About 1 in 3 women in such cases may be successfully managed expectantly. So you may go ahead with the expectant management provided these criteria are fulfilled. Okay. Now coming to the non-tubal ectopic pregnancy, and that is what we are going to discuss under the role of ultrasonography. Okay. So non-tubal ectopic pregnancies are less common but cause disproportionate morbidity. They often present late and hard to diagnose. Okay, and they include interstitial, cervical, caesarean scar, heterotopic, cornual, ovarian, abdominal pregnancies, etc. Okay, so these pregnancies we have discussed in detail last time. So we'll just read out the signs of seen on the ultrasound. So interstitial ectopic prevalence, remember, it is 1 to 6% of ectopic pregnancies. Implantation is present in the interstitial part of the tube, and key ultrasonography sign is the interstitial line sign. That is echogenic line connecting endometrial cavity to the sac. Okay, so this is an interstitial line sign. The sensitivity is around 80%, specificity is around 98%. It presents later with higher beta SCG values. So even beta SCG in interstitial ectopic may not be that, it may be near about 50-60% rise you will get, okay, or maybe normal also. So 3D ultrasound helps to visualize connection between the cavity and sac clearly. So apart from 2D, you may use the 3D ultrasound also. Okay. So this is what is the image of the 3-dimensional image showing a coronal view of the uterus with right-sided interstitial ectopic pregnancy. See, here is the uterus. You can see the uterus, and this is the interstitial pregnancy which has grown. Okay, so this is the 3-dimensional image. Okay, and this was successfully managed with the intramuscular methotrexate. Okay. So actually this is not given in the talk article, but I have just thought I should say the timing of rupture of various ectopic, because interstitial pregnancy grows quite big as compared to the other parts of tubal ectopic. Generally they rupture around 6 to 8 weeks of gestation, but the interstitial, because it is surrounded by the myometrium, if you see the thickness of the interstitial portion, if you see the histology, it has got a myometrium which is more distensible, so they can grow up to 8 to 16 weeks. More often around 12 weeks they can grow. Okay, so the beta SCG value may be normal also in this particular patient, but when the rupture is going to be massive and life-threatening hemorrhage. Okay, because it is going to be a cornual, very vascular portion. While the rest of the tubal ectopic, they will rupture around 6 to 8 weeks of gestation. Ischemic region has got a narrow lumen. Ampullary portion, it has got a thinnest wall and early distension, and fimbrial portion does not have a support, so there will be tubal abortion into the peritoneal cavity. Okay, while cervical, it has got a implantation into the fibrous cervical tissue. This can also grow little larger. Ovarian, around 6 to 8 weeks, there is a limited stage of ovarian tissue. The condition is rare but can cause a severe bleeding. And abdominal pregnancy can go late, even second or up to third trimester also. The diagnosis most of the time missed in the abdominal pregnancy. Okay, and implantation outside the uterus allows the prolonged growth, and fetus may survive to the viability, and placenta removal is risky. Okay, so this is I just wanted to along with the flow share with you, but otherwise this is not a part of the talk article. Now next is the cervical ectopic, that also we have seen last time. The empty uterus, barrel shaped cervix will be there on ultrasound. Gestational sac will be below the level of the internal os, and most important is a sliding sign. Sliding sign will be negative. Where will be the sliding sign positive? If it is an incomplete abortion, in that particular case, the products will move separately. Okay, so in miscarriages, this sliding sign will be positive. Okay, and there will be peritopoblastic blood flow on the color Doppler. This may be part of your question somewhere. Okay, negative sliding sign. The next is a cesarean scar pregnancy. There is a registry in the UK that is called as UK Early Pregnancy Surveillance Service, UK EPSS, established to track and study such cases. And according to this diagnostic criteria are G-sac, gestational sac is outside the uterine cavity, implantation into the previous scar within the myometrial mantle, and there is a sustained peritopoblastic flow on color Doppler. Okay, it needs to be distinguished from miscarriage, and the sliding sign helps. Okay, so cesarean scar pregnancy will also have a negative sliding sign. Okay, it should be managed in specialist centers due to diagnostic challenges, and diagnostic criteria are not yet validated. Next is a heterotopic pregnancy, that is simultaneous intrauterine and ectopic pregnancy, or you can have a scar pregnancy along with the intrauterine pregnancy also. Okay, so this is common with assisted reproduction. There is only one pregnancy which is not common with assisted reproduction. Not common in the sense with the advance of ART, most of prevalence of most of the non-tubal ectopic pregnancies is increased, except the abdominal pregnancy. It has remained constant even with ART also. Okay, so often misdiagnosed as a singleton or twin intrauterine pregnancy. The key point is that presence of intrauterine pregnancy does not exclude ectopic, especially in ART patients. Okay, so you always think about the heterotopic pregnancy, and sometimes there can be diagnosis which is asked. They may give you some values also, and in heterotopic pregnancy also beta HCG of no value. Okay, so conditions in which beta HCG will not be helpful, one of the condition is a heterotopic pregnancy. Okay, so that finishes our first article. Okay, thank you.